I want to tell you about Patricia. She was 67 years old, recently retired, active in her community, and by every standard measure of her own judgment, healthy. One Tuesday morning, she woke up feeling off. Not dramatically sick, not in the kind of pain she would have described as an emergency, just off. Her jaw ached in a way she attributed to grinding her teeth during sleep. She felt unusually tired despite a full night of rest. Her stomach was unsettled, and she wondered if something she had eaten the night before had disagreed with her. She felt vaguely short of breath when she climbed the stairs, but told herself she had been less active recently and probably needed to get back to her walks. She took some antacid for the stomach. She rested. She told herself she was probably coming down with something. She did not call her doctor. She did not go to the emergency room. 3 hours later, her husband found her unresponsive on the kitchen floor. Patricia had been having a heart attack for the better part of a morning and never knew it, because what she experienced looked nothing like what she had always understood a heart attack to feel like. No crushing chest pain, no left arm agony, no dramatic collapse at the moment of onset. What she experienced were the symptoms that the research tells us affect women significantly more often than men during cardiac events, and that are dismissed, minimized, and fatally misinterpreted by women and their physicians every single day across this country. I'm Dr. Matthew Carter. Today's video is one I feel a specific urgency about because the gender gap in heart attack recognition is not a minor statistical footnote. It is a documented, persistent, life-threatening disparity that is killing women over 65 who are doing nothing wrong except not knowing what to look for. Subscribe now and please watch this video to the end because the information in the second half could be the most important thing someone you love hears this year. Let me start with why women over 65 experience heart attacks so differently from the textbook presentation that most people have internalized from decades of public health messaging. The classic heart attack image, the middle-aged man clutching his chest and collapsing, is not fiction. It is an accurate representation of how myocardial infarction most commonly presents in men. The problem is that it was derived from research that for decades enrolled predominantly male participants. The landmark clinical trials that defined our understanding of heart attack symptoms, presentations, and outcomes were conducted in patient populations that were 70 to 80% male. The result was a clinical picture of cardiac events that described men's experience with precision and women's experience with significant gaps. In women, the pathophysiology of heart disease itself is often different. Men tend to develop coronary artery disease through the familiar pattern of large vessel obstruction, plaque building up in the major coronary arteries until blood flow is critically reduced. Women develop this pattern too, particularly after menopause when estrogen's protective vascular effects are lost. But women also develop coronary disease through a distinct mechanism called microvascular disease, dysfunction of the small arteries and capillaries that supply the heart muscle, at much higher rates than men. Microvascular disease produces ischemia, inadequate oxygen delivery to the heart muscle through diffuse small vessel dysfunction rather than a single large blockage, and the symptoms it generates are characteristically different from the classic large vessel occlusion presentation. They are subtler, more diffuse, more easily attributed to other causes. A study published in Circulation, the flagship journal of the American Heart Association, found that women were significantly less likely than men to experience the classic chest pain presentation during acute myocardial infarction. Instead, the most common symptoms in women, particularly women over 65, were unusual fatigue, shortness of breath, nausea or stomach discomfort, jaw or neck pain, back pain between the shoulder blades, and a sense of generalized weakness or malaise. Let me go through each of these in detail because the specificity matters. The first and most consistently reported symptom of heart attack in women over 65 is unusual fatigue. Not ordinary tiredness from a long day, not the fatigue of poor sleep, a fatigue that feels qualitatively different, heavy, pervasive, and disproportionate to activity level. Research published in the journal Circulation found that in a study of women who had experienced heart attacks, 70% reported unusual fatigue in the days or weeks preceding their cardiac event. 70%. It was the single most common prodromal symptom, and it was almost universally dismissed by the women themselves and by their physicians as stress, overexertion, depression, or simply aging. The second symptom is shortness of breath that occurs either at rest or with minimal exertion and feels out of proportion to the activity being performed. In women with cardiac ischemia, breathlessness can appear without any chest discomfort whatsoever, walking from the bedroom to the kitchen and arriving slightly breathless, climbing one flight of stairs and needing to sit down before feeling recovered. This breathlessness is the heart's way of signaling that it is not pumping efficiently, that the oxygen supply to cardiac muscle is compromised. It is a symptom that women consistently attribute to deconditioning, to weight, to pulmonary causes, or simply to getting older. It is, in a significant proportion of cases, a cardiac warning. The third symptom is jaw, neck, or throat discomfort. This catches almost everyone off guard because pain this far from the chest does not fit the mental model most people carry of where a heart attack should hurt. The mechanism is referred pain, the same phenomenon that causes left arm pain in classic heart attacks. The nerves that supply the heart share pathways in the spinal cord with nerves that supply the jaw, neck, and upper back. When the heart is ischemic, pain signals travel these shared pathways and are experienced by the brain as originating in the jaw or neck rather than the chest. Patricia's jaw ache was not from teeth grinding. It was referred cardiac pain, and her physician, had she called, might very well have attributed it to the same benign cause she did. The fourth symptom is nausea, indigestion, or epigastric discomfort, stomach symptoms that feel for all the world like a gastrointestinal problem. The vagus nerve, which runs from the brainstem through the chest and abdomen, connects cardiac tissue to the gut. Cardiac ischemia stimulates vagal responses that produce genuine gastrointestinal symptoms: nausea, bloating, a feeling of fullness, or what women often describe as an unsettled stomach. Research consistently shows that women are significantly more likely than men to receive a gastrointestinal diagnosis in the emergency room when they are actually presenting with a cardiac event. The antacid that Patricia took was treating a symptom whose actual origin was her heart. The fifth symptom is upper back pain, particularly between the shoulder blades. This is another referred pain phenomenon, and another symptom that is almost universally attributed to musculoskeletal causes, particularly in older women with known arthritis, osteoporosis, or prior back problems. The clinical picture becomes even more complicated by the fact that these symptoms frequently appear together rather than in isolation, and that they tend to be less severe and more gradual in onset than the sudden dramatic presentation of classic male pattern heart attack. This is why researchers use the phrase silent heart attack, not to describe an event with literally no symptoms, but one whose symptoms are quiet enough, diffuse enough, and plausibly attributable enough to other causes that they do not generate the alarm response they should. A study published in the Journal of the American Medical Association found that women who presented to emergency departments with acute coronary syndromes were significantly more likely than men to be discharged without a diagnosis, to wait longer before receiving an ECG, and to receive less aggressive treatment once admitted. The symptom gap was producing a care gap with measurable and devastating consequences. I want to spend a moment on the specific risk factor profile that makes women over 65 particularly vulnerable, because understanding your own risk level is the foundation of taking these symptoms seriously. After menopause, women lose the cardiovascular protection provided by estrogen, a protection that had been suppressing arterial inflammation, maintaining vascular flexibility, and supporting favorable cholesterol metabolism for decades. The result is that cardiovascular disease risk in women increases sharply after menopause and continues rising with each passing year. By age 65, women's heart disease risk approaches and in many measures equals men's. Yet the cultural perception that heart disease is primarily a men's disease persists powerfully in the minds of both patients and disturbingly some physicians. Hypertension in women over 65 is a particularly strong cardiac risk factor. Stronger, according to some research, than in men of equivalent age. Diabetes doubles cardiovascular risk in women, but increases it by approximately 50% in men. Sleep apnea, which I have covered in earlier videos, has a particularly strong association with atrial fibrillation and cardiac events in older women. And depression, which affects women at roughly twice the rate of men, is now recognized as an independent cardiovascular risk factor with a direct biological mechanism involving inflammatory pathways and autonomic nervous system dysregulation. Here is exactly what I need you to do with this information. First, update your personal mental model of what a heart attack can feel like. For a woman over 65, a cardiac emergency may present as nothing more dramatic than a jaw ache, an unsettled stomach, unusual fatigue, and the vague sense that something is not right. That combination in a woman over 65 with cardiovascular risk factors deserves immediate medical evaluation, not watchful waiting. Second, know your personal risk factor profile explicitly. hypertension, diabetes, prior smoking history, elevated CRP, elevated cholesterol, a family history of cardiac events in female relatives, and a prior history of preeclampsia during pregnancy are the factors that lower your threshold for acting on ambiguous symptoms. Third, if you have not had a formal cardiovascular risk assessment in the past 2 years, request one at your next appointment. Ask specifically for a calculated cardiovascular risk score using your complete health profile and ask whether a resting ECG is appropriate. Fourth, if you experience any combination of unusual fatigue, jaw or neck discomfort, shortness of breath with minimal exertion, upper back pain between the shoulder blades, or nausea without obvious cause, and you have cardiovascular risk factors, do not wait and see. In the context of a possible cardiac event, the cost of an unnecessary emergency room visit is a few hours of your time. The cost of waiting when it is real is measured in a completely different currency. Fifth, share this information with every woman over 65 in your life. Women who have been specifically informed about the atypical female presentation of heart attack are significantly more likely to act promptly on those symptoms. That awareness is the intervention. Comment below with one of 3 responses. Comment sharing this with someone if you are sending this to a woman who needs to hear it. Comment: "This was my story if you or someone close to you experienced a cardiac event that presented this way." Or comment what I watch for if you have updated your symptom awareness and want to share what you now pay attention to. I read every comment. I'm Dr. Matthew Carter. Subscribe now. Next week, I am covering something that will surprise you. Your dentist may be seeing signs of your stroke risk before your cardiologist does. Take good care of yourself. The information you now have could save your life or the life of someone you love.